Um, it is very much a pleasure to be here. When Elizabeth and Andre asked if we would like to talk at this summer school, very, very anxious to do so. I have my undergraduate, my master's degree in health information science at UVic, and I just really feel I owe a lot to this school. They gave me a fantastic education, and it certainly has served me well throughout my career. So I'm more than happy to give back in this way. So the purpose of this discussion is really, Catherine and I are going to share our experience and approach dealing with the highly complex informational needs we faced during the course of the pandemic. And we're going to include some real life examples of our visualizations, analytics, and surveillance reporting. I hope there's going to be lots of time at the end for some questions. And as well, I'm hoping that we're also going to have a little bit of time to show kind of a fun video. We developed it with someone kind of like a Canadian celebrity, and so I really hope that we can move through this presentation, so we have a few minutes to show that at the end as well. So I'd like to begin by honoring the Algonquin and Anishinaabe people on whose traditional and ceded territory the city of Ottawa is located. The Algonquin and Anishinaabe Nation have lived on this territory for millennia. Their culture and presence have nurtured and continue to nurture this land. We remain committed to the reconciliation and anti-racism efforts at our Ottawa Public Health and renew our intentions to contribute to the building of a more just and inclusive Canadian society. And also want to say happy Indigenous Peoples Day today. So to set some context about Ottawa Public Health, we are the second largest population center in Ontario. We have about 1 million people in terms of our population. And, maybe another fun fact is that, our geography is pretty big. We really do sprawl. We can fit Calgary, Edmonton, Toronto, Montreal, Vancouver, all within our geographical boundaries of our municipality. In terms of the role of Ottawa Public Health, we improve the population's health by positively influencing the social and physical environments where we work and live and play. And if you look at our core services, you see we do, a whole lot more than just COVID or monkeypox or look at infectious diseases. We have a very strong focus on the prevention side of things, upstream interventions and societal factors that influence health. So much, almost all of what we do is in partnership and collaboration. We have many, many intersectoral partners, healthcare. We work very closely with education, social services, housing. We think the advantages of the work that we do to improve the population really means that we're drawing less on resources in the form of healthcare and social benefits. And they say that, for $1 invested in public health, we save $14 in future healthcare costs. So that's a little bit about who we are and what we do. They say that public health is working when it's invisible. It's just not in the focus of people's day-to-day lives. But of course, March 2020, we suddenly found ourselves in the spotlight, somewhere where we don't really want to be. And we also had to, pivot just pretty much on one major priority. So we were very much on the front line of the local pandemic response, and we played a prominent role from case and contact management, outbreak management, surveillance, certainly conveying information and advice to the public and to decision makers, and of course leading the vaccination campaign. We, in order to get all this done, we redeployed our 700 staff. Almost all our 700 staff were redeployed to COVID, and we also had mass recruitment as well. We hired at one point at the peak, we hired 3,500 staff. We're not at that level today, but at the very peak we were. We led the largest vaccination campaign in Ottawa's history, and to date we've achieved a 92% vaccination coverage for people aged 12 and older. Definitely this collective action saved lives, reduced the spread of infection and hospitalizations. And maybe I'll just pause for a second to acknowledge that, sadly, 817 people in Ottawa have died of COVID. And each of these 817 souls were valued, loved, and continue to be missed, and will forever be remembered by their families, friends, neighbors, caregivers, and colleagues. As it relates to kind of what we're going to be talking about today, epi reporting, surveillance, it's always been key, always been a really important part of public health. to help uncover gaps and monitor. But certainly it has never been more important than in the past 2.5 years. So busy slide. I love this slide. I'm not going to go through it a lot, but early on in the pandemic, I really liked this slide because it kind of sort of talks about what are the key interventions, the key actions in different phases of a pandemic. I think this slide was created well before the pandemic. But in times of chaos and uncertainty, I like frameworks, and this was a really kind of a nice framework to take some of the chaos out. This isn't a public health discussion today, so I'm not going to go into the different interventions and actions, other than say that the big point here is the community has different needs during each stage of the pandemic, and so the community has different needs during each stage of the pandemic. So therefore, the informational needs of the different stakeholders are different for each and every stage. And so really, throughout the pandemic, it was a constant assessment and continuous quality improvement of our products. And this was completely vital to inform our response, and also properly communicate and inform the community, residents, businesses, media, the province, our board. I think the key point on this slide, and maybe throughout the presentation, really is this last sentence at the bottom, is access to timely local data is the foundation for decision making and to inform and guide the development of the right public health policy and public health actions, which then needs to be communicated, understood by, and responded to by individuals and communities at risk and decision makers. So that's the essence of what we're going to be talking about today. So the amount of data, it was just astronomical. The demand was something we've never seen before. Catherine, I'm sure, is going to be talking about this. In terms of sources of data, it's not like, I'm sure you guys are talking quite a bit about hospital information systems and things like that. It's not one big system that all this is housed. Mostly comes from disparate systems, often local systems. We need data from other sectors as well. There's wastewater, there's data from schools and labs and hospitals. Somehow we have to stitch this together. So pretty challenging in terms of a key source of data. Another key source of data is we commissioned lots of surveys and polling to assess, understanding and uptake of our measures, immunization, mental health consequences, and things like that. OPH was the first in the province to create a system to collect race-based data related to COVID-19 infections. So we collected this in immunization and case management, and we did this in a way that was supported by the community and safely communicated back to communities to guide our actions during the pandemic. During the past 2.5 years, there's also been major advancements in technology. I don't have time to go through a lot of them today, but really, two of the big ones were provincial. They never really paid a ton of attention to public health in terms of technology in the past, but they launched a provincial contact management and tracing system, and also our immunization system. And so these were incredibly important to us to do our job. So in terms of analysis, reporting, visualization, things we really want to talk about today, there are some key tenets, that we really try to follow is related to this. Like, keep it simple, make access easy, make it simple, make it easy to understand, and really foster high trust. And that means a lot of data quality. That was one of the most important tenets that we followed throughout. So Catherine's going to talk about, internal and external, Power BI dashboards, infographics, and special reports and things like that. But maybe it's good to mention that, this was a new disease. And so, initially, really limited and fast and frequent guidance came out, left, right, and center definitions, practice changes all over the place, to follow these tenets, of simple, easy, foster high trust. That was really hard. To do that, we really had to, rely a lot on automation, and not just the front end, not just really cool, Power BI dashboards and things like that, but on the back end, automating as much as possible as well to make it sustainable and to keep up with all these changes. And data quality was so important. I would say, from a resource perspective, from a dollar perspective, we probably spent 2 or 3 times more on data quality than we did on the actual epi team and who were actually doing the reporting. So we had, each of the major teams had quality improvement teams. We had quality dashboards and processes, and so this was something that was certainly very, very important. So I think I'm at the point where I'm going to pass it over to Catherine, who's really going to give you some real world examples of what we went through and what we used and developed. Catherine, over to you.
Awesome. Thanks so much, Cameron. That was a great overview of everything that we do. So let's get into the nitty gritty of real world examples. And so here you can see a mock-up of our dashboard. Sorry, I'm just trying to, okay. You can see a mock-up of our dashboard, sorry, not our dashboard, our web page on the Ottawa Public Health website. And you can see we have a ton of different data. So from COVID-19 dashboards to reports to links to our community partners. Our most popular resources are the COVID-19 dashboards with an average about 15,000 viewers a day. So they're very, very popular and so very much in demand. So we have one for cases, testing and outbreaks, and the other one is for vaccination. And during the height of the pandemic, these dashboards were updated daily, including statutory holidays, because we were working 24/7. For the geographically curious, we had our COVID-19 data available at local geographies. And I'll talk a little bit more about that shortly, but we had cases, testing, outbreaks, and vaccination data available at local geographies. Then we had what Cam talked about, which is the survey results. So we have an impact, like a section called societal impact, where we talk about those different surveys that went out at different time points in the pandemic that were really looking at taking a pulse on how Ottawa residents were feeling, how they were doing mentally, physically. Did they feel safe and supported throughout this pandemic? And so very, very interesting information that's available there. We also have, for those looking for specific answers to questions, our in-depth reports that look at hot topics like employment and COVID-19, institutional outbreaks in schools. So whatever the topic, we had these special reports that were going out during the pandemic. And then the last 2 buttons are actually for data housed by our research partners at Carleton University and the University of Ottawa. So we are incredibly lucky in Ottawa to have Dr. Rob Delatola at Carleton University and Dr. Doug Manuel at University of Ottawa, who are leaders in their fields. So with Rob, we have wastewater COVID monitoring in wastewater that was really groundbreaking across Canada. So we were one of the first to have open data related to COVID-19 in wastewater, which is really exciting. And then infectious disease modeling with Doug's team that was looking at using census data from hospitals to look at doing projections for COVID-19 and for hospital beds, and then now using wastewater, and then for a while using our reproduction rate data that was open data at the time. So really, really interesting stuff, and a lot of different partnerships that we developed throughout, well, that we strengthened throughout the course because we were already working with them on a lot of other stuff outside of COVID. And so on our website, we also have lots of supporting documents for all the products that we've created. They're not necessarily just put out there for people to just go off and good luck. We try to give supporting documents to really explain how the data has changed over time, how outbreak definitions, for example, have changed over time. We have a little bit of change management related to using dashboards that are interactive as opposed to PDF reports, which is how we started. And we also have a ton of open data. So Cameron, if you want to switch to the next slide. So in Ottawa, we've released over 14 COVID-19 data sets, 14 in French and another 14 in English. And that doesn't include all the different versions that have happened out there. And there's been a lot. And collectively, those have had over 1 million downloads. So very, very popular. And they're actually the most downloaded data sets on Open Ottawa. So we've taken over. And the Open Ottawa team has been absolutely amazing throughout this process. We couldn't have done it without them. And on average, our most popular data set is the demographics for cases and deaths, and that was downloaded by, on average, 5,000 users a week at its peak in 2021. And then more recently, we're looking at around 2,000 downloads a week. So still a very high viewership. despite the fact that we're entering recovery, they're still very much unpopular and very much used by our community. And fun fact for those of you who are going to be working in health informatics and looking at automating these types of things. So these are open data are actually automatically generated by our Power BI dashboards. So the way that I've built most of our dashboards, the ones that I've worked on, they do all the data analysis, all the reporting, and they automatically generate all our open data. So it's all seamlessly done using our visuals on hidden pages in the dashboard. So fun tip if ever you are looking at doing that kind of work and streamlining some processes in your workplaces or future workplaces or current workplaces. Next slide. Now that you know what's out there, let's talk about how we got there. So our COVID-19 reporting journey has been just that. It's been a journey. We've basically been flying a plane that we're building at the same time. And so we started with 17-page PDFs, static PDFs that were given kind of really very comprehensive outline of what was going on with COVID-19 that also had outbreak PDFs. And these were across multiple different websites that we were manually updating. And that's merged into 2 different interactive dashboards that were on our website and open data associated to those, which has now merged into one dashboard that has all the data, so much more fulsome data, more branding, some better formatting, a lot of feedback. Everything was built in with feedback from our community partners, from our teams, our different OPH teams, so from our users, internal, external, the general public. So a lot of feedback from a lot of different sources as we grew our different products and grew ourselves in what we were able to do. So our capacity also grew during this time. And now as we enter recovery, we've reformatted the dashboard again to really focus on what we can measure at this time and what is valuable information at this time and can help guide our decision making as we enter this recovery process. So there has been definitely a transition throughout. Next slide. So now let's look at the wider context of COVID-19. So in the background here, we have COVID-19 cases, so Ottawa residents with COVID-19 reported by the day that it was reported to Ottawa Public Health, and our different dashboard, well, our different products that were released at different timelines. And so here you can get an idea of the surges and where we were at in the pandemic, where all these different data products were released. And so as you can imagine, in the beginning of the pandemic, the reporting needs were monumental. They were urgent. Everyone needed data yesterday, but the data itself was constantly in flux. Case definitions changed, data systems were being built. We were learning about COVID-19, which was a novel virus at the time. So that's a very different environment than in the middle of the pandemic, where the data needs were still monumental and very urgent, but there was much greater variety of data. There was also a much bigger amount of data to process, but there was more meat on the bones. So we could actually do more in-depth analyses, start to ask those different questions about health equity, for example. So it was an interesting time for data analysis and data processing. And now as we enter recovery, the data is changing again, and our ability to report on various metrics is changing as well. So the landscape has changed throughout the pandemic. And so everything that we release has to be flexible. It has to be able to adapt to change to this environmental context. So just something to keep into consideration. When you build reports, you don't just leave them out to die. You need to take care of your babies. And yeah, start with the skeleton. So build up a nice strong skeleton, and then you can add the muscle later on. Don't wait till it's perfect, because then you'll never grow out and you'll just be your own worst enemy, really. So it's okay. It won't be perfect. Just get it out, get that skeleton, and then add the muscle later. Next slide. So our open data journey, our journey in general started on March 10th with our first Ottawa resident that had COVID-19. And basically a couple of weeks later, we sent out a request to our digital solutions team for help to really start develop all these business intelligence solutions. And so it started with, you want to press a button? There we go. So it started with the request of, we needed 6 dynamic reports. So 2 for the public and then 4 for internal purposes. Next button. And then we needed to streamline all our data sources, because we had data coming from everywhere on many different platforms, some that you have to access internally, some that were online, etc. We needed to automate our data transformations. So really to try to remove all these manual steps and across different statistical platforms. We needed to share our reports internally and externally. And we needed to make it super easy. So it was a one-stop shop, no login required. You just had the data and it was all there. And we needed our data updates to be regular, so at least daily, sometimes twice a day. And so that needed to be scheduled. And then last little click, perfect. The most important, it needed to be secure at all times. So public health information by law is protected. So this was a deal breaker. So we needed a system that was secure at every single point in time. So yeah, it was a huge ask and they totally delivered. So we worked with them collaboratively for the next couple months and started developing a whole bunch of internal dashboards that went live. And then eventually our external dashboards went live. If you want to click. And yeah, so at first and until we went live with these dashboards, our public reporting basically was this PDF with a whole bunch of outbreak tables on our website. So very, very manual and labor intensive. Click, click. Awesome. Now, during this time, we were actually able to release our ward map, and that was the first time we released geographical information for COVID-19 at smaller geographies. And I think we were the second municipality, the second municipality in Ontario to do this. So really, really exciting, and it made the media. We were very, we were very excited. But yeah, so that was on May, and then just a little bit later in June, we released our first ever dashboard, and this was a huge, huge success in the sense that the city of Ottawa Public Health, nobody within our municipality had ever published a public Power BI report. So we were really kind of breaking open the door to a new way of processing data at the city and in OPH. And so these dashboards went live on June 9th, and it was 2 reports with some open data associated to those as well. Okay, click again. And then the moment we went live with version 1, I started working on version 2 because we knew the first version was the skeleton. It was, okay, we don't have time to look at formatting. We don't have time to make it perfect. We don't have time to add all that extra data. We're going to have to do that with the next version because we need time, and we're not going to get time until we get this automated process going. So that's what happened. And then we went live with version 2, which was ticked all our boxes, and I'm in love with our version 2 of the dashboard. And so it has tons more information. The formatting has changed. There's more branding. We have a lot more functionality. Our open data is a lot more fulsome. Everything is integrated into one report as opposed to 2 separate reports. So we weren't updating 4 things. It was just 2 things, one in English and one in French, and all our open data. So very exciting. And we released it in the middle of a surge because of course we did. Next little click, perfect. And then a week after that, we released our neighborhood level information. So in a pandemic, you cannot work alone. You don't work in a vacuum. You need your community partners. And so we were incredibly lucky to work with the Ottawa Neighborhood Study to produce these COVID-19 dashboards on their website and to release this data at a meaningful geography, which is neighborhoods. And I'll talk more about the ONS a little bit later. But that's about the time that we went live. Now, the next big step was the migration from the COD, which is the system that we were using for case management in Ottawa, to the provincial system for case management called the CCM. And that was a huge endeavor with months of training for all our staff, which I think at that point we were in the thousands for staff. And basically what happened is we were given the green light, okay, we're going to start reporting from CCM. And what that entailed is our reporting needed to be seamless. We did not want the public to be kind of jarred with a completely different dashboard and data that didn't line up. So it had to be identical, even though it was a completely different database. So we did very extensive QA and case matching across the 2 platforms. We built brand new extracts that were just for the dashboard from CCM. And we just rebuilt our whole process to facilitate that reporting from CCM. And we did that in 2 weeks. So it was unreal, but we made it happen, and it worked. It was a very successful transition. Our dashboard looked pretty much almost exactly the same. We lost 1 visual because that one was we were still doing some QA on it, but eventually we got it back as well. So yay. And that's it. Yeah. So that was on March 10th and right before the next surge. So it was good timing. And then finally in this presentation anyways, not the final part of our journey because our journey's not done. Who knows what we're going to be in a month from now, let alone a year. But the last thing that I'm going to talk about is the vaccination dashboard, which went out on March 30th. So that was right in the middle of the biggest surge that we had at that point, but very much a hot topic at the time. because vaccine had just started rolling out. Okay, click again. Now, so those were examples of our reporting or general COVID-19 reporting, but I really wanted to give you an example, and Cameron as well, of cross-disciplinary collaborations. Now, I truly believe that some of the most impactful work happens when people from different perspectives and different work experiences come together. So on the left, we actually have the results of a PEJEC network analysis, which is something that we routinely run during the pandemic and just in general for infectious diseases. And it basically is contact tracing. And it was developed following a major sports and social cluster of confirmed COVID-19 cases. So the cases are red circles, the blue dots are exposure locations, so where people were exposed, and the red and green diamonds are contacts, so people that were in contact with a confirmed case. And as you can see here, the PEJEC analysis for the uninitiated is a giant mess. Like it's just a whole bunch of lines, and interpreting that is a process. And so what happened is Anjali, Dr. Anjali, who's a part of our team, she worked with the comms team to develop this beautiful social media post that tells a story. So it transforms this very liney, dotty graph into something that's actually understandable, relatable, and shares a story and a message. So it's basically, we had one person that was symptomatic that played a sports game, and unfortunately other people got sick from that game. And some of those then attended another social event, and so it spread again. And so we have multiple spreading events that happen because of that first initial case of playing a sports while symptomatic. And so it really brings home the idea of staying at home when you're sick, wearing a mask, and that spread can happen, and it's unintentional consequences of our actions, everyday decisions. And so basically over 23 days, we had 26 confirmed cases, 274 contacts. We had, I think it was 5 high schools that were impacted, 14 cohorts that were dismissed from school, and 1 long-term care home impacted. So quite a lot of people that were impacted by these decisions. So yeah. Thank you. Now, and that brings me to actually the last point, well, the last issue that I'm going to talk about, which is actually one of the most foundational to the work that we do in public health. And the reason why it's so foundational is because the social conditions and the environment where we live are actually better predictors of health than our genetics. And there's a ton of research behind that. So this is just one visual from the Canadian Medical Association, but there's a ton of data around that. Click again. And for that reason, pre-pandemic, public health units across the province, well, across Canada, really, but across the province, our province of Ontario, we're working to improve to understand these inequities. So there were a lot of different survey work that was happening to really develop social determinants of health questions and related answer sets. And during the pandemic, there was early anecdotal evidence that COVID-19 was disproportionately affecting particular groups of people. And so in response to this, the Ministry of Health added social demographic data fields to CCM and to COVAX, but it was in response to, it wasn't by design. And so the scope of that data collection and the reach of that data collection and the timelines around that, because it was done once those systems had already been in place for a while, it wasn't the same as something that could have been developed from the get-go. And so really the idea now is, as we enter post-COVID-19 recovery, we really want a standardized suite of social demographic data that's going to enhance efficient collection and use of data, social demographic data, for equitable planning across the province. We want to be able to measure what counts, where it counts in the systems where we're doing this data collection, so that we can actually report and slice and dice it and look at it in meaningful ways and make evidence-informed decisions. Now, unfortunately, in the absence of these very large and robust record-level data sets that have social demographic data, we need to link data, so health data, so not just COVID-19, but health data to social determinants of health. And we do this using neighborhoods. And that's where our Ottawa neighborhood study comes into play in Ottawa. We're incredibly lucky to have the ONS. It was developed in 2006. And the goal of the ONS is to understand the social and health inequities across Ottawa. So it was developed by Dr. Betsy Christensen and Mike Sawada at Ottawa U. And they look at exploring the ways in which neighborhoods affect the health and well-being through the social determinants of health. And what's beautiful with the ONS, it's the boundaries themselves of the neighborhoods are actually developed in consultation with the community. With everybody shows up at a table every 5 years, and they discuss the boundaries of their neighborhood. So you have residents of that neighborhood, you have business administrations, you have folks from the city who are coming together to discuss these boundaries and really how that represents them. And it really facilitates that data-driven decision-making at all levels, really resource allocation, program development. So we've been working with ONS for years now, way long before COVID-19 to share data. And click. And so, as you can imagine, the ONS have been champions for community development and engagement in Ottawa for decades. And so we were really lucky to be able to leverage all the work that they've done and the platform that they have, the Ottawa Neighborhood Study platform, to share COVID-19 data at meaningful geographies and on a platform that is so robust and allows us to contextualize that data because they have all the other neighborhood level data. So it's been a great partnership in this context, but also in general. And to really bring home the idea of health and equity, this is data and why it's so important to look at health equity. This is data from February 2020 to June 2021. And in the graph, we have the 111 Ottawa Neighborhood Study neighborhoods, or I think a section of them. And then against that, on the y-axis, we have the cumulative COVID-19 rates in those neighborhoods. And in red, those are the neighborhoods that are most disadvantaged on the social economic index developed by the ONS. And that index looks at education, employment, income, family composition, and housing needs. So it's a pretty comprehensive index. And you can see that 17 of the 24 neighborhoods with the highest overall infection rates are those neighborhoods that are the most social economically disadvantaged. So this speaks a little bit to that piece of health equity and how can we support health equity. So yeah, next slide. Now, in all this process that we've gone through for reporting for COVID-19, it's the people, the processes, click, and the technology that have really allowed us to do all the work that we've done. It would just simply not have been possible. So for people, it's been one city, one team of everyone working together to build capacity, to share knowledge. We've had our community partners, the ONS, Carleton University, University of Ottawa, and everyone's been there every single step of the way, supporting each other, working together to really address all these big issues and in times where everything is urgent to actually make things happen. The processes, we've done so much automation, and that's allowed us to do a lot more in much smarter, more efficient, and more accurate ways. So it's relieved a lot of the opportunities for just data weirdness. So it's allowed us to do more better. And then finally, the technology itself. So this is going to sound like a plug, which is weird, but Office 365 has just been amazing. So we use Teams, we use SharePoint, we use Power BI all the time. And the fact that it's all integrated into one system has made everything so easy. So we're incredibly lucky to have all this technology at our fingertips right now, because we've done everything remotely because pandemic. And so it's allowed us to do an insane amount of work. And I guess finally too, for you watching us, it's really the ability to do dashboards using anything right now. There's so many different options for you to build dashboards software. So Tableau is what we use for the Ottawa Neighborhood Study dashboards. We use Power BI, but there's so many options out there. So the world is your oyster for when you're going to be developing stuff. And that's it for me.
Well, thank you, Catherine. Yeah, you mentioned that we're so lucky to have the technology. Well, we're so lucky to have you. In fact, I think today, didn't it come out that you and the team won some beautiful award for all the work you've been doing over the past 2.5 years? So a big congratulations. And yeah, we couldn't have done this without you for sure. So big thank you. I think we do have enough time. I see we're closing in, but I think we have time to pivot just a little bit. So I'm kind of happy about that. So yeah, you know what? Foundationally speaking, it's all about the analysis, about the data, the visualizations, the dashboards. Of course, we need that, right? But we also need other ways to grab people's attention, and social media as Catherine actually talked about, was very important. And so at Ottawa Public Health, we rely on this a whole lot. In fact, when we just think about Twitter, I think we have more followers than any other public health unit in North America. And there's a reason for it, because we have just an amazing team. And so here's an example of some work that they did. So this is an example of a tweet. So it was right after Super Bowl, and the team wanted to set up a discussion about misinformation. And so on purpose, they sent this out. So what an amazing Super Bowl. Congratulations to and then in parentheses, Bruce, make sure to put the winning team here. And then thanks to everyone who stayed home and watched the game with members of their household. We know this wasn't the usual way to enjoy the game. We thank you for your efforts. Kind of like Bruce, insert the winning team logo here. And we sent this out exactly like this on purpose, okay? Again, we wanted to maybe kickstart a conversation about misinformation. Poor Bruce, but at the same time, it did its job. We sent this out, it went viral. People were trying to, what are you doing? Ha, ha, ha. And so we got the conversation we wanted around misinformation. It was excellent. But then we decided to take it to another level, okay? And then since then, we've taken it to a couple more levels, but that's okay. I'm not going to go into that. But what we decided to do was really focus in a little bit on Bruce. And so this is a little video I want to show you. I hope you can hear this.